welcome. So I think
Yes, sir.
Dr. Mariam and Dr. Heba, you both only two of you are there, but okay, it's okay. People can join.
Yes, sir.
So, uh, I am Dr. Koushik Tripathy. I am a practicing retina consultant in Kolkata.
Right.
Uh, I am thankful to Professor Muthuswamy sir, Vijaya Paranjpe ma'am, Khada ma'am, and the other faculty members of Muthuswamy Virtual University who helped us pass the exam and who are continuing to help other people. So this will be a exam, and the time will be 4 minutes. If you are not speaking, you do not prompt, and if you are not the candidate, mute. So basically, point is that this is a mock exam. You have to relax. This is just a test of your preparedness. You can take time, but we'll give 4 minutes only. Do not hurry. If you do not know, just answer that I do not know. Basically, in exam, the examiner wants to know what you will do, and they actually want to make you pass. So basically, they want to see whether you can. You should not miss a vision or life-threatening disease, and you should not harm a patient. So that is what they want. So because ophthalmology is a single branch, do not say that I'll refer to this retina consultant or something. You say that I'll collaborate with the retina consultant to provide the best possible outcome or best possible management for the patient. You have to practice history taking. You have to practice evaluation and examination and management of all patients of all specialties, and specifically focus on the areas or specialties which you are a little less confident. And if you have any questions, you can add to the Zoom chat. So who will volunteer first? Dr. Mariam,
Yes, sir. Okay.
introduce yourself.
Yes, I'm ready.
Please introduce from.
Mariam Hussain. I'm in Karachi, Pakistan, and I am enrolled to appear in Cairo in June.
Okay, are you practicing any specialty or you are doing comprehensive
No,
ophthalmology?
no, no. I'm comprehensive. I'm not subspecialty trained yet.
Okay, so there is this patient, a 30-year-old male who is complaining of dimness of vision in the left eye. You examine the fundus. This is like this. So how would you evaluate this patient and manage? How will you manage this?
Right. Sir, could you please, I can't see the entire picture. Could you please position it a little?
Okay, are you
I'm
in
on the,
mobile or something?
yes, I'm on mobile.
Okay.
Maybe if I, thank you. Thank you.
Is it visible?
Yes, it's better. Thank you.
Hmm.
Okay. So
So
this is a fundus. Yes,
and this is the OCT which is seen.
right. So this is a fundus photo of a right eye, and the
This
disc margins.
is right eye.
Sorry, yes, sorry, left eye, left eye, left eye. The disc margins are clear. The retinal vasculature, the inferior arcade appears of normal course and caliber. The superior arcade, supratemporal. Uh, in the periphery of the supratemporal arcade, I'm seeing cotton wool spots, and I am seeing some vascular attenuation, and there might be NVEs, but I'm not sure because the view of that is not very good.
So what will be other
Um,
differentials? The white spots, other than
yes,
cotton spots, what could be other differentials?
other differentials could be exudates, but exudates tend to be more central, so not
Which,
exudates.
which exudate?
It could be
No,
okay.
no, no.
It
Exudate.
could
What are the types of exudates?
uh hard and soft.
Okay. What is this kind of exudate? The things which are there near the arcade. If it is an exudate, what would be this thing? How would they be called? These white things.
This seems to suggest more of an infectious or an inflammatory component because we can see that it is clustered around a particular vessel. So perhaps more suggestive of
Okay. So
vasculitis.
it can be cotton spot or
Right.
soft exudate. So what if it is infectious or something? What could be the like these white patches in the retina? What could they be?
I don't know. I'm not able to answer that.
So may I?
Yes.
Could it be retinitis, sir? Because the white patches are probably obliterating the underlying blood vessels, and whitish appearance is typical and with ill-defined margins, little fluffy margins. Probably
Yes.
localized retinitis. Uh,
Yes. So this is a
Hello.
Yes, I think Dr. Koushik might be having connection problems.
Other differential. Hello, Dr. Koushik, are you there? Dr.
No,
Hema.
I think
Oh,
no, I think he's lost connection. All right, Dr. Sam, continue. You were describing. He'll come back.
yeah.
We know he'll be there.
And actually, the picture is gone. I'm not able to see the fundus.
All
Uh,
right, but
yeah.
talk us through your reasoning.
Yeah. Okay.
What
yes.
happened?
Is it visible now?
Yeah. Now it's visible.
Yes,
Sir.
yes, sir. Yes.
Also, to describe the blood vessels are looking a bit.
Let me
Yeah.
let me reshare this. Yes. So what is the analysis? So it can be retinitis. So if it is retinitis, what can it be? And what does the OCT show? Dr. Sam,
Yeah.
what is
Yeah. So we see. I'm audible. Yeah. Under OCT, we
Dr.
can
Sam,
see
what is your full name?
Rajan Ponraj, Rajan Samuel Ponraj. But I
Okay.
have labeled my name as Rajan Ponraj for identity. Yes.
Okay.
Yeah.
So what is the
Yeah.
finding in the
Yeah.
OCT?
Yeah, so the OCT is the OCT of the fundus corresponding to the left eye fundus. If you see in the media in the vitreous, there are some there are few moderate dot reflectivities which are seen. There is also a posterior a posterior hyaloid like membrane reflectivity, which is above the retina, and there's a convoluted contour of the retina, of the inner surface of the retina, and we see the
So what are these echoes?
SRF.
What are these reflectivities in the vitreous?
Those probably could be those vitreous dot echoes. Sorry, dot reflectivity. That probably could be suggest of vitritis.
Vitreous cells, not vitreous.
Vitreous, yeah, vitreous, sir. Yes, sir. Yes,
So
sir.
if this patient comes to you, how will you manage this? What could be the differential diagnosis? How would you investigate and how would you manage?
Yes, sir. Sir, may I know the age of the patient, sir? I'm sorry, I heard one.
Around 30, 35-year-old male.
Okay. Considering this, I would also like to have a look at the fundus of the other eye also.
Other is normal.
Normal. Okay, sir. So, so it's a unilateral presentation. Um, um, I think my differential would probably be an etiological source of a viral component, viral etiology for retinitis. Probably I could.
Along with retinitis, what are the other findings?
There is
Retinitis. So,
vitritis.
what is
There
the
is
around the phobia? What are these?
sorry, sir.
Around the fovea on the right side and the left side, there are some yellowish dot. No,
Yeah, yes, yes. The yellow dots are probably there could be some fibrin like protein deposits.
is fibrin yellow or dot like? Does fibrin appear like that? Dot
Sorry, sir.
like? Does fibrin appear like dots, yellowish dots? It is like dot. No.
Yes, sir.
What would these be called? These yellowish dots which are around the fovea, nasally and temporal to the fovea. So I think we are like we cannot give like more than 5 minutes for this.
Yes.
So This is retinitis. Yes, retinitis and
And SRF, yes, sir.
yes, retinitis and corneal spots
Got
are
it.
different cells, but there are hard exudates. These are hard exudates around the
Okay.
So this
Okay.
is an exudative kind of thing which is happening, and there are ACs, retinal cells in the like vitreous cells are there, and there
Yes.
is a subretinal fluid. So because there is some supratemporal disc involvement, you can do a blood pressure on in this eye. And point is, this kind of exudative retinitis is a typical feature of post-febrile retinitis. These patients usually have a history of fever on like few days back, and they can be caused by multiple infections, including Bartonella and Rickettsia. So please
Got
read about like post-febrile retinitis. This is
post. Okay.
likely not be given, but I wanted to discuss because the retinitis is something which we need to know, and we need to discuss the differences because it looks like corneal spot. You also need to do blood pressure.
Okay. Sir, the disc is also looking, does the disc also look edematous and it's
Yes, yes.
yes.
This superior, at least in the superior part and temporal part, this looks a little edematous. And as you can see, the retina is edematous too in the superior part because the retinal, there is whitening. The choroidal details are not prominent in the inferior part, but in the superior part, the choroidal details are not much prominent. So that suggests that retina, there is a opacification of the retina, or retinal transparency is a little reduced.
Yes. So
So
FFA would be suggest FFA also for such
yes,
cases, sir.
yes,
I will want to
yes.
look for any pinpoint leakages. Yes. Okay. Sir.
Yes,
Yes.
FFA should be suggested. FFA, OCT, and systemic investigations. You need to do blood pressure, CBC, ESR, VDRL, HIV,
Yes.
do chest X-ray, and specific because corneal spots are there. You can also suggest toxoplasma IgG, IgM,
Okay. Sir.
and tests for Bartonella and Rickettsia.
Okay. Sir.
So
Thank
yes, and then you'll plan accordingly.
Yes. Sir.
And A would be like homework would be to read how to treat post-febrile retinitis. So who will take? I want a new name to discuss this case. This patient has both eye similar kind of picture. Both eye he is complaining of floaters. 40-year-old male. Dr. Sham, I want somebody else to.
Okay, sir. No problem. Yes, sir. Sure. No. Thank you, sir.
Dr. Heba,
Yes, doctor.
please introduce yourself. I think you close one device.
Dr.
Okay.
Heba, turn your
I will
speakerphone
just
off.
mute myself. Unmute myself. I'm Dr. Heba. I am working. I'm comprehensive ophthalmologist working in KSA. I will appear by the end of this year. Planning to appear by the end of this year for FRCS3. As far as I see, this is a color imposed photo, like having false color, greenish for the posterior
What
segment.
is the
I
most
can.
likely imaging modality here, Dr. Heba? What is the
Uh,
most likely imaging modality?
excuse me, I did not hear you because I have a problem in voice. Can you repeat, please, Dr.
So
Kaushik?
what is the machine which has been used to capture this image? What is the
The false,
modality?
the SLO, false coded,
Okay.
false, yeah, images, yes. This is a superimposed image having
Why
false
super
color
why superimposed?
because the retina is appearing greenish in color.
No. That is the like feature of this device. So is it a normal field, or is it something somewhat the field is larger? What is this called? The photo.
White field.
Yes, white field pseudo color image of which eye?
I think this one is the left eye.
And what
Uh,
does so?
it has some like opacities, pre-retinal, mostly in the vitreous, and I can see that the superior and inferior.
How are you sure that it is in the vitreous and not in the retina? How do you
Be-
determine whether an opacity is in the vitreous or in the retina?
because I feel that the retina is behind the. Yeah, yes. Because the blood vessels are
Is it
partly
retinal
displaced.
or pre-retinal? How do you know? Let's just tell me, how do you know that something is pre-retinal?
Because I can see that the retinal, the optic disc, the macula are a bit behind, and I can see also that the retina is a bit elevated.
No. That is not how you should answer. You should say, if something is in front of the retina, I will not be able to see the retina or the retinal vessels. So these
Okay.
whitish patches, though they are there, but retinal vessels are not actually obscured or not blocked by this. So these are not pre-retinal. If something is pre-retinal, you will not be able to see the retinal vessels.
Yes.
Okay, so this is not what is happening. The obviously whiteness is there and it is around the vessels. So that is why it is appearing a little edematous or something, but it is not pre-retinal. Pre-retinal things will block the things which are behind. So it is not blocking. So I am saying that the retinal whitening is retinal only. So what would be? This is around like 60-degree kind of whitening in the peripheral retina and some. What is the
Retinitis, retinal infarcts.
retinitis? So if it is retinitis, what kind of retinitis would it be? A patient has a similar picture.
Posterior uveitis.
Yes, posterior. Retinitis will come in posterior uveitis. So I am asking if the patient has similar appearance in both the eyes. So what would be the diagnosis or what would be this retinitis called?
Retinitis.
No, that is there can be like how what would be the diagnosis or how would you like determine which kind of retinitis is it? Can it form a specific kind of syndrome here? If there are peripheral 360-degree retinitis?
White dot syndrome?
No.
I'm
So
not
it
sure.
can be acute retinal necrosis.
Yes, it can be. It is acute retinal necrosis because there is 360-degree peripheral retinal involvement. So white dot syndromes, in white dot syndrome, most of the times white dot syndrome involve the posterior pole, and they are because this is white dot, so they are like dots. So this is not dot. These are confluent white things. This can start as a dot or small round patches, but here they are all nearly confluent, and there are some satellite type of lesions, but this is mostly confluent. You should not tell that this is a white dot syndrome. This is retinitis. The first you have to know, and there are some intraretinal hemorrhages also, but prominently retinitis is there because the peripheral retina is predominantly involved, and there is some media haze which is presumably due to vitritis. So most likely the diagnosis is retinitis or acute retinal necrosis, and because both eye are involved, so this is mostly bilateral acute retinal necrosis. So we are already like crossing time. Just I'll request you to read what are the differences between acute retinal necrosis, PORN, and CMV retinitis, and the like post-febrile retinitis and toxoplasmosis retinitis, and how to manage. Okay, so this will be the reading A for the any if there is any query I can take, or I'll go to the basically this is just to stimulate your reading, and you have to read. Just do not speak something which you do not know, because the examiner will take you to somewhere where you do not want to go, and it will be difficult. If there are no queries, I'll go to the next. So just read, okay? Because basically in exam, you do not say this is normal, this is abnormal. No, do not focus on the normal things. You focus on what is abnormal and try to go to the diagnosis or go to what you are seeing. Because the time is of vital essence. If you are losing time, then you will not be able to see the more OSCEs. The more cases you see, the higher are the chances of getting a good number. So
Doctor,
yes, doctor.
can I ask a question, please?
Yes, please change your name. Yes, what is your name?
Mariam Fathi.
Okay, Mariam.
Can this be a progressive outer retinal necrosis?
Progressive outer retinal necrosis can also be a differential here, but usually progressive outer retinal necrosis is unilateral. It can be bilateral also, but it is usually posterior pole. The involvement is mostly on the posterior pole, and there is retinal whitening and retinal hemorrhages, maybe not so much. So progressive outer retinal necrosis, because it happens in immunocompromised patients, the vitritis, which is here, which is causing the media to be appear a little hazy. It is not there, and progressive outer retinal necrosis is usually in the posterior pole, usually involve the posterior pole, and there is something, some changes which are seen in around the vessels. Can anyone tell what is that seen in what is the sign in PORN in which there is paravascular clearing?
I think occlusive vasculitis.
No, you'll have to read. Occlusive retinal arteriolitis is seen in acute retinal necrosis. I am asking if there are retinitis in the posterior pole, but there is some clearing around the vessels. What is that called? You'll read and post. So I think I'll go to the next. So who
Okay.
will volunteer here?
Okay, thank you.
Yes, can you are Dr. Mariam, no?
Yeah.
Yes. So can you volunteer for this? This is a like 30-year-old female who comes to you with dimness of vision, like hand movement vision in the right eye, and the features are like this. The other eye also has similar kind of feature, but it is in the periphery, whiteness and redness, red dots in the periphery of the left eye. The right eye is having this. So what could this be, and what are your findings?
Okay. I can see a picture of the of the left fundus. The disc
This is
is
right eye or left eye?
sorry.
This is right fundus or left fundus?
This is the right fundus.
Okay. Then
Okay. I can see papillites with severe hemorrhage and the peripapillary hemorrhage. I can see also upper temporal exudates and hemorrhage. The lower retina seems to be more or less normal. There is no exudate.
I say that this patient has HIV. This patient is diagnosed to have AIDS. So what would be the diagnosis in such a scenario?
This may be, I can put first in the differential diagnosis cytomegalovirus retinitis.
Okay, what are the points in favor of that?
The indolent retinitis that appears with hemorrhage, some vasculitis.
Yes, basically retinitis with prominence of hemorrhage, and the vitritis or media clarity is, vitritis is not bad. Media is reasonably clear. So how do you treat if it is CMV retinitis? How would you treat? How would you evaluate and how would you treat?
I will treat if the patient is immunocompromised.
Patient has AIDS. So if patient has AIDS, is he immunocompromised or not?
I think he is a immunocompromised.
No need of thinking. AIDS full form. What is the full form of AIDS?
Sorry?
What is the full form of AIDS? What is the full name of AIDS?
Okay. The abbreviation?
Yes. What is the full form of the abbreviation? If
Deficiency syndrome.
okay, so there is immunodeficiency in the name, no? So that means there is immunocompromise here. So how would you manage?
Okay. I would manage. I should count the CD4 cells. I should be in a collaboration with an internal medicine and internist.
Yes.
Valgan cyclovir. Okay. I can administer 900 milligram twice daily for 3 weeks.
Yes.
Intravitreal injection of ganciclovir or foscarnet. Okay. I can give steroids.
Which steroid will you give?
Intravitreal or systemic administration.
So what is the problem of giving steroid in CMV retinitis? So patient is already immunocompromised, no? Why do you want to increase the immunocompromise here? So typically in CMV retinitis, we do not give steroids. So do not utter anything which is not written or which is like which you do not know clearly. So you are going right, but do not give intravitreal dexamethasone or any steroid in a patient who has obvious infectious disease, and specifically definitely not in CMV retinitis. So valganciclovir, and if needed, intravitreal valganciclovir can be given. Before valganciclovir, what specific workup should be done? What are the side effects of valganciclovir?
Okay. I should treat the complications as if there is retinal detachment with vitrectomy and endo laser?
No. I am asking before you start valganciclovir, would you do any blood workup?
Yeah. CBC for neutropenia to elicit if there is neutropenia or not.
And
Sorry.
and
And
other than
bone
CBC, do you
bone
do
marrow
anything?
aspirate? No, bone marrow aspirate?
Yes, no, you may not do bone marrow aspiration for this, but you definitely need to do CBC and also do a kidney function test, urea creatinine.
Okay.
Okay. I think you did good, but do not tell you will give intravitreal dexamethasone or steroid in CMV retinitis in a patient who is already immunocompromised. That might worsen the things. So we do not do that. So I think we'll go to the next step. Point is you need to read CMV retinitis in detail.
Okay.
So
Thank you.
I thank you. I'll go to the next. Who will volunteer? I want somebody new. Anyone, please. This is just a mock exam. This is not something. I am not judging you. I am just trying to help you on how you can focus on your weaknesses to improve yourself so that you are more prepared in the exam. Anyone?
Okay, sir. I'll try. Actually, I don't know.
So this patient is having floaters in the left eye, and vision is 6/18. So this is what you see in the fundus. So what could be happening here?
Sorry, again, tell me the question again.
Dr. Hiba, please introduce yourself.
Yeah, I'm Dr. Hiba Mansour from Egypt. I'm appearing to the exam next June in Cairo.
Okay. Do you practice any specialty?
No, I am not practicing it.
Okay. So this is a patient, suppose it is 33-year-old male who is complaining of floaters in the left eye and dimness of vision. The vision is around 6/18 in the left eye. So what do you see here?
So it is 30 years old?
Yes, around 30-year-old female or male, but left eye has floaters and dimness of vision. What do you see?
I can see that the media is opaque, which denoting vitritis. And also I can see surrounding the optic disc there is looks like serpiginous retinitis.
What retinitis?
Serpiginous.
Why is it serpiginous?
It's starting from the disc and extending.
So the typical description of serpiginous is retinitis or choroiditis. If it is serpiginous, the typical typically does it cause retinitis or choroiditis?
Choroiditis.
Yes. So how do you differentiate choroiditis from retinitis? Is it choroiditis here or retinitis here?
No, it is retinitis. I think it is retinitis.
Okay. So
Fluffy mark.
how do you differentiate retinitis from choroiditis?
It's whitish in color. Choroiditis will be deep in color, and also the margins are.
Choroiditis will be deep what? You said retinitis is whitish in color. I agree. What is the color of choroiditis?
Choroiditis will be deep yellow.
Yes, deep yellow. Okay. And location wise?
And also the margins will in retinitis is fluffy, are fluffy, while in choroiditis it's well distinct.
In retinitis or choroiditis, in both cases, if they are active, the margin may be fluffy. So the point is location. In retinitis, because it is in the retina, so retina will be opaque, retina will be white. But in choroiditis, retina will be clear. The choroid will be yellow. That means the changes will be subretinal, not retinal. So here the changes are retinal. So I am saying that there is vitritis and there is a retinitis here, which is like the retinitis is coming out, like you are seeing the retinitis through the haze of vitritis. What is the typical appearance called? Like you are seeing a retinitis patch through a haze of vitritis. What is the typical appearance called if such a thing happens? And suppose there is a pigment near the white.
Temporarily, there is like a scar, just a papillary
Yes.
scar. So
There is pigment.
I think it may be a picture of toxoplasma.
Okay, then what is that appearance called?
What?
What is this appearance called? Like there is vitritis, haze, and through the haze you are seeing some whiteness.
Light and fog.
Yes, headlight and fog appearance. So
Light and fog.
Headlight in fog appearance. So basically, we have already crossed 5 minutes, but the reading you will have to read like how you treat toxoplasmosis, how you evaluate toxoplasmosis, and also how you treat toxoplasmosis in pregnancy. So I'll want somebody. Basically, this is something you will read. I'll not tell the diagnosis here. This is a little rare. So this is a young male, 12-year-old male who has similar appearance in both eyes. He's not recently not recognizing his parents and he's falling. So what could be the diagnosis? This would not most likely come in your exam, but I am showing this image. Just keep this in image. Specifically, people who are interested in retinal and uveitis, just read about the disease. What can it be? So this I want Dr. Abhinaya to take. Dr. Abhinaya, please introduce yourself. So this is a patient. He noted that he noted sudden like dimness of vision in this eye, and
Hello.
what is happening? This is the photo which is there, fundus picture. So what is this?
Hello, sir. Can you hear?
Yes, Dr. Abhinaya, please introduce yourself.
Yes, sir. I'm Dr. Abhinaya. Currently, I'm not practicing, sir. I'm a MS ophthalmologist.
Okay. Just tell us, this patient has recently noted a visual decline in this eye, and his
Okay,
what do you see and how would you approach?
This
What do you see? Just tell us what is visible here.
this is a FFA picture.
This is FFA picture. Why is this FFA picture? In FFA, do you see any red? In any
No, sir. No,
is
sir.
there any color other than black and white? Have you ever seen that?
No, sir.
So why then would it be FFA image?
No.
So what would this image be? Look, this is not an exam. I am just here. I just want you to be prepared. Okay. Just say what you are seeing. Which eye is this? Right eye, left eye?
This is the right eye.
Okay. And what is visible here?
Actually, I don't know what is this imaging modality.
This is fundus camera, color fundus photo. Okay. Because the vessels are reddish and the retina is visible. So what is visible here? This white thing, what is that? So I think I can take any other candidate if they want to answer. So what can this be? Any candidate? So this has some feathery kind of appearance, no? The like fiber like appearance in the specifically temporal to the fovea. Okay. Any candidate, can anyone please like volunteer? This is not an exam and nobody is going to like judge you or fail you. So you can like have a guess also. So basically this is extensive myelinated nerve fiber. So I put it because the retinitis also appears white, but if there is myelinated nerve fiber, that can also appear white. The feature suggesting myelinated nerve fiber are that this thing is actually following the retinal nerve fiber layer. As you can see, like in glaucoma, you have read, no, the nerve fiber layers appear like this. So you can actually see those things if it is myelinated. So it would be your homo would be what is Stratsma syndrome. Okay, and the like systemic associations of myelinated nerve fiber. So I'll go to the next candidate. Who will volunteer here? Anyone who has not volunteered before? Dr. Asma?
Yes, sir.
Yes. So,
Dr. Asma Ismail from
yes,
Egypt. I will appear in the exam in the June, inshallah, Cairo.
okay. So this is a patient who has this kind of appearance. In which eye is this? And he is also complaining of floaters. Middle
Okay,
age.
it's right eye. Right eye.
Yes.
I think there is a vitreous haze,
Yes.
vitritis, and there is a lesion just near the optic disc, punched out lesion below the optic disc. Is it right? Or
What is the punch? What is the punched out lesion? No, there is something infratemporal to the disc. No, what is that? What do you see there?
I think it is punched out lesion, or what's that? Retinitis.
So there is something white lesion, and there are what is there near the fovea or inferior to the fovea? What is visible? So
There is dark.
another thing is that in exam, most of the times the images will not be very clear. They purposefully keep those things to make things more difficult. So this kind of picture will only come. So basically, I say that there is a white patch and there are some pigmented areas. You know what the fovea, infratemporal, temporal, supratemporal to the fovea. Then what would be the diagnosis here?
I think this is a case of vitritis.
Yes.
I will
No,
take
vitritis and white patch infratemporal to the disc with some pigmentation around. Like what
okay.
the diagnosis or this white? What is this white patch?
So it's maybe also a toxoplasmosis with old and recent lesions.
Yes. So basically, whitish patch with vitritis, you have to look up, you have to consider retinitis. So this is the retinitis with vitritis and pigmented patches are there here and there. So this is most likely active toxoplasma choroiditis, which has reactivated. Okay.
Okay.
How would you
Okay.
manage? How would you manage? Now, what investigations would you do, and how would you manage this case?
I will take a history from the patient of of eating raw meat or treating with cats. I will complete ocular examination. By ocular examination, I will take a IgM and IgG titer for toxoplasmosis antibody. Okay, and also I will take toxoplasma antibody titer PCR.
What?
The anterior chamber tabs.
Okay, PCR for what? Toxoplasma.
Toxoplasma antibody titer for PCR for anterior chamber tabs.
What? PCR for what?
From the anterior chamber tab. Or maybe diagnostic vitrectomy.
Okay, no, you can go for diagnostic, but that we usually preserve for people who are like who have poor vision in that eye. So because most of the times toxoplasma diagnosis is clinical, so most of the time you can go away without vitrectomy or vitreous biopsy.
Okay.
And also
So
you have to check the other eye. Other eye. You have to always say that I'll see other eye. That is very important.
Okay.
So okay, toxoplasma diagnosis is confirmed. So how would you treat? How would you treat?
I will give him vitamin.
Vitamin, okay,
and folic acid
and
every other day, and sulfadiazine.
Okay.
And I will maybe add steroids.
Okay, when do you add steroid?
After 24 hours after beginning.
Okay. And how would you know that the disease is responding?
I will see that vitritis is cleared, the vitreous
Yes.
may be cleared,
Yes.
and the recent vitritis maybe disappear.
How do you know that retinitis has healed? How do you know that retinitis
will be pigmented?
Yes, it will be pigmented, and what will happen to the margin?
I can't remember. Margins.
Okay, read about it. How does like how do you know like this thing is responding? So you think you did very good, excellent. So just just read about. I have kept few photos of toxoplasmosis because this is very important, and there is very high chance that you will be given a case, at least in OSCE. So I'll go to the next. Who will volunteer here? So this is just a mock exam. I am just trying to help you. So this is a patient who comes to you and he recently says that his vision was good and currently he is having a dimness of vision in the left eye. Right eye he had poor vision right eye. I'm also showing this right eye is having like this feature. So left eye is having this. So Indian male, 40-year-old. So any Dr. Rofida? Dr. Rufina, are you here? So, yes, Dr. Rufina, please introduce yourself and please take this.
Yes, I am with you. I am Faida Hajo from Sudan. I am anterior segment.
Okay. So this patient has come to you with recent onset decline in the left eye. He is Indian born. And how would you like proceed with this case? What do you see in the left eye? This is right eye or left eye?
This is a fundus photo of the left
eye. Yes.
eye. There is there is a white lesion throughout all the fundus, and there is also a scar near to it also around the macula and around the arcade optic disc.
So the other eye is also having similar type of thing.
It's free.
What would be the diagnosis here? What is the diagnosis?
It is posterior uveitis. It's a wide differential.
What? No, posterior uveitis. What kind of uveitis?
With retinitis.
What? Retinitis or choroiditis? Why? What is this?
Retinitis.
So look, this is something.
Retinitis because it is white lesion. Most of them.
Retinitis. This we call retinitis, and this was retinitis. Okay, white, and the choroidal vessels are not very much seen through this. So and this. So is this retinitis or choroiditis? Where is the lesion? Is it in the retina or it is in the?
Oh yeah, it is near yellow lesion. It is, I think, choroiditis.
So please remember and see multiple images of retinitis and choroiditis. Confused. This is subretinal. The things which are there, they are below the retinal vessels. Retinal vessels are prominently seen, but the changes which are there, they are behind the retinal vessels. So this is subretinal thing, and this is choroiditis. This is not retinitis. Retinitis is dark white. Look here, dark white or dark yellow. This white and this.
Yes, sir.
This white is kind of thing, this peripheral white is yellowish thing, but because and in retinitis you will not be able to see the choroid because retina is all white. Choroid will not be visible through that. So do not confuse between retinitis and choroiditis. This is choroiditis. So why is the patient complaining recently? Why not why is he complaining like that? Like 1 week or 2 days or 3 days he is having dimness of vision. What is happening here?
There is macular involvement, I think, or cystoid macular edema. We do OCT.
There is macular involvement. You cannot see cystoid macular edema. What do you see if there is cystoid macular edema? In fundus photo, how do you know that there is cystoid macular edema?
Yeah, we find macular thickening. We suspect that there is macular thickening.
If you are saying that there is cystoid macular edema, you should be able to appreciate cysts, which appear like round or transparent like areas in the fovea. It is not visible here.
The fovea.
Look, like compare the peripheral pigmented areas and central areas near the fovea. So what is the difference between these two lesions?
I think this.
Do you see any color difference between the central lesions, like lesions just supranasal to the fovea and intratemporal to the fovea, and the lesions which are near the arcade? Are there any color changes or they are similar color? So basically, just I'll tell you because we are losing time.
There is color changes.
Basically, no, basically in the periphery, in the near the arcade, the things are more of white and black, and the margins are very much well defined. But the thing which is near the fovea, they are yellowish type of color, and the margin is fuzzy. So this is active choroiditis, which is threatening or involving macula. That is why they are having this thing. And OCT macula will not usually show like major features here. So you can do angiography to see what is the like activity of this. But clinically also it is prominent that there is this active choroiditis. So basically this is an active, this is a case of serpiginous choroiditis or geographical helicoid peripapillary choroiditis, which is now going to involve the fovea, and that's why patient is having the problem. Your A would be, how would you work up this thing? What is the relation of TB with this, and how would you treat? That is your homework. And this this kind of serpiginous choroiditis can be given because it is quite common in Indian subcontinent. Okay, so this is how in the left eye also same kind of picture, old A. And this patient who will take this is a child, like a 10-year-old child. He has poor vision in both the eyes. Both eyes has similar kind of feature. So what could this be, Dr. Nema? Yes, please introduce yourself.
I'm here. I'm Dr. Ali Nema from Baghdad. Well, this is a large coloboma-like lesion. This is the fundus photo of the right eye, showing a large scar, coloboma-like.
Okay.
Presented with poor vision, this child, you said?
Yes, both eye poor vision since birth. What could this be?
Lower congenital amaurosis.
Leber congenital, yes. So what are the features in, like if it is leber congenital amaurosis, what would be the refractive error?
Well, the child poor vision with probably nystagmus.
No. My question is different. If you think that this is leber congenital amaurosis, what is the refractive error you expect from him?
Refractive error?
Yes.
I'm not sure.
Hypermetropia.
Yes, hypermetropia will be seen. And also, if it is leber congenital amaurosis, there will be, because leber congenital amaurosis is a kind of retinitis pigmentosa only, which is severe. So you will be most likely seeing arterial attenuation or pigmented changes somewhere, but it is not visible. So what could be other differentials?
Well, toxo scar.
Yes. So toxo scar should come in the front, like in the first DD. Definitely in patients with leber congenital amaurosis, you can also see macular coloboma. So why is it not macular coloboma? Why is it toxoplasma scar? Congenital, basically, this is, you are saying congenital toxoplasma scar, yes?
Yes.
So how do you differentiate a macular coloboma from a congenital toxoplasma scar? And what does it appear like?
Probably the size.
Size
of the lesion.
I think that can be same both sides, but it is your homework. How would you differentiate macular coloboma from this? Basically, point is the toxoplasma scars usually have pigmentation, and if it is only coloboma, it can be just absence of the retina and choroid there, so it will be white-like thing. If it is just macular coloboma, okay. And definitely, I am showing toxoplasma again and again because toxoplasma is very important and it will come. Just read about everything about toxoplasma. Okay. Who will volunteer next?
Doctor.
Yes.
Why this is not central areal chorioretinal atrophy.
Please repeat. I could not hear you. Please say your name.
Chorioretinal
Dr. Heba, yes.
atrophy.
What is your question?
Central, Heba from Victoria. Central area. Why this is not central areolar chorioretinal?
You are not audible. Can anyone please hear Dr. Heba?
He's asking why is it not central areolar chorioretinopathy. That's what I heard.
Okay, central areolar chorioretinopathy can also be a differential, but when does the central areolar chorioretinopathy present? And also this kind of lacunae kind of thing, you can see that there is a pigmentation and there are areas of white areas between the pigmentation, which is actually causing a radial spoke-like pattern. So these are typical of congenital toxoplasmosis. In central areolar choroidal dystrophy, usually there is a foveal atrophy. This is a round-like thing, but that will be mostly beaten bronze kind of appearance with a single kind of color, like pigmentation, but it will be a single round area. There will be no this, as you can see, this area is heterogeneous. There are pigmentation, there are areas of depigmentation also, and there is a excavation. The lesion looks to be little excavated. Though central areolar choroidal dystrophy can also be excavated, but usually there is a like central blackish or area of foveal atrophy, which is round. So that's how you, and also you will tell me, you will read about the typical age of presentation, and you'll put a photo of the differentials of this thing, Dr. Heba. Okay. Hello.
Hello.
Yes. Dr. Heba, just read about the differentials of congenital toxoplasmosis and put a photo of each. Then you will understand like what is the difference.
Okay.
Okay. So I'll go to next. Who will take this? Dr. Hala. Dr. Hala, this is a 20-year-old male. Dr. Hala, this is a 20-year-old male. He complains of dimness of vision in both eyes. And he doesn't have any, he doesn't take any medications or anything. He just saw that vision is less in both the eyes. Both eye has similar picture. So what do you see and how would you like evaluate this person?
This is fundus photograph of the right eye showing disc edema and hyperemic. I cannot recognize the cup. It's almost obliterated. The edges are blurred. The arcades, the superior and the inferior slightly dilated, slightly engorged with flame-shaped hemorrhages. Corresponding all over.
What you said engorged. What is engorged?
The veins a little engorged.
Okay. Do the veins like how do the engorged veins look like?
More thick.
So what is the usual AV ratio? What is AV ratio?
It's
just look at this. I say that there is no like at least vascular engorgement here. Okay. So just there are hemorrhages, but
flame-shaped hemorrhages.
If you say vascular engorgement, venous engorgement, then what would be the diagnosis?
Okay, there is still flame-shaped hemorrhages and exudations.
No, I am just asking you if you say or if there is like venous engorgement here, so what would be the diagnosis?
If venous engorgement, it will be vein occlusion.
Yes, so if vein occlusion is there, if CRVO is there, central retinal vein occlusion, then the hemorrhages will be everywhere or just focused around the disc. So it is only around the disc. In other areas there is no this thing. Okay, so just you have to keep on running, like thinking behind your head also, because these veins are not engorged. Once you see the engorged veins, you will understand that this is there.
Yeah, okay.
There is edema, hemorrhages, and what is the
exudations, macular star.
So how will you evaluate what is happening? Other eye is also having similar feature.
And I'm not sure this is big growth spot or what. This
You can say that there is whiteness in the center. You can say that this is hemorrhage, or you can say it can be a rough spot. But in rough spot, usually the central area, the central white area is more white, not like this.
Okay.
So
Yeah, because the photo is not in good resolution.
clear. Yes.
Yeah.
So if this thing is in both the eyes, similar feature.
It
So
could be CMV.
what?
It could be CMV.
CMV, both eyes, CMV, but for CMV, it is retinitis. So where is the retinitis here?
Okay.
Okay, for retinitis, there will be
Yeah,
retinitis.
because what is this down white patch?
So that can be retinitis, but how do you explain the hemorrhages at other places?
Okay.
Okay, so for retinitis to be there, there should be white patches everywhere, like at least near the hemorrhages, somewhere there should be this thing. So it is not there.
Okay, so it's papilledema.
Okay, if there is papilledema, what is the first most important bedside which you should?
Malignant hypertension.
Yes, so you'll have to do malignant hypertension, PP.
Because of the macular star and the flame-shaped hemorrhages and the disc.
Yes, so the diagnosis will be clinical diagnosis. You have to rule out malignant hypertension here. And this can be the white patch, can be a cortical spot, which is there in the intertemporal part. And are exuded both eye papilledema, and it usually in papilledema due to some cerebral cause, like idiopathic intracranial hypertension, will not have this amount of like hard exudates in the fovea. Usually doesn't have. And also cortical spots or hemorrhages can be around the disc, but it usually doesn't reach beyond the, like near the fovea or beyond the fovea. Okay, so
and in the vascular conditions or leukemia or AIDS,
yes,
yes.
You'll have to do that also. You'll have to do CPC for this patient also. And what would be the most likely cause of BP hypertension in this case, in this 20-year-old male?
Maybe renal disease, pheochromocytoma, maybe.
So you need to do kidney function test for this patient. So do you have hypertensive retinopathy, because there are whitening and redness and this are exudate, etc. So it can be missed. So that's why I kept it here. So who will take the next? Dr. Mariam, did you take? I think you took a question. Yes.
Can I ask a question, please, first?
Yes, please.
Why this is not a neuroretinitis?
Yes, this can be neuroretinitis, but in neuroretinitis, the hemorrhages, this kind of hemorrhage, the flame-shaped hemorrhages, which are almost going outside the, like if you draw a like vertical line from the fovea, which is almost crossing that, it will usually not happen. Neuroretinitis is typically just disc edema and macular star, but this kind of hemorrhages which are there and the cortical spot which is there, that makes neuroretinitis a little unlikely. But definitely neuroretinitis will be a differential. And also neuroretinitis is typically not in both eyes. Usually it is unilateral, but it can happen in both eyes also. Definitely you keep neuroretinitis as a differential here. But this kind of hemorrhages, the extensive hemorrhages which are there in the disc, they are typically not seen in neuroretinitis.
Okay, thank you.
Yes, in differential you can definitely tell that. So who will, Dr. Mariam, did you volunteer before for any case?
Yes, sir, I am. First question.
So anyone who did not volunteer, I want to take you. So take you. This is a patient, fast post-op day. This was a soft cataract, and you used very less energy, equal energy, and fast post-op day. You are saying like this. The pressure is around 36, and patient is having poor vision on the first day. So what could be the reason, and how would you proceed?
I will give some thoughts.
Please volunteer. Who are you? Please.
I will examine the anterior chamber and evaluate.
What, Khala?
Sorry?
What will you examine?
I will examine the AC, the anterior chamber. I will evaluate the depths. I will examine the cornea. I will examine the posterior segment. I will check the reflex of the, if I will put in mind the choroidal detachment. I will put in mind also the.
Why do you think there is choroidal detachment if there is the pressure is 36? So how does choroidal detachment come into play here?
The pressure is 36.
Yes, I said that this is A, and there is the IOP is a little like 36. The phaco energy used was not very high, and it was a soft cataract, and it was all, well, other routine cases are doing fine. This case has this.
So
So
this,
what would be
what
your diagnosis here? If
what
if this thing happens on the first day of post-operatively, and the cataract was not very hard, there is it. What is visible? What is visible here? The slit film photo.
this is not striate keratopathy?
Yes, this can be striate keratopathy. And what could be the cause? Because you have not used very high this thing, high power, and there was no gutty, nothing. So what could be a differential in the first post-op day?
And the AC is shallow or deep?
AC is deep. AC is deep. AC is small. There are cells in the AC, and this thing, the cornea is like this.
And the fundus?
Fundus is easily visible attached, and the ultrasound, you did ultrasound is, doesn't have any. Like, you will have to tell this. I should not tell this. You should tell that I'll do ultrasound, and ultrasound is not showing any echoes in the vitreous. So what could be the diagnosis here?
Yeah, so no infection and no choroidal detachment and no.
Look, choroidal detachment will not come here because the IOP is high.
Mm.
With choroidal detachment will cause IOP high. What is the IOP you will?
Suprachoroidal hemorrhage will cause.
Yes, suprachoroidal hemorrhage will cause also high
So
IOP.
ultrasound will exclude that.
If there is serous choroidal detachment, what will be the IOP? If there is serous choroidal detachment, what should be the IOP?
Detachment hypotony.
Yes. So do not say, like, suprachoroidal hemorrhage is a very rare scenario. Do not tell it here. Like, you have to be like, the examiner is asking what could be the diagnosis here. On the first post-op day, the cornea is so white, and you are like, there was not much use of this thing. And this is a Uveitis mock exam.
And there is pain? There is pain or not?
What?
Pain. It's painful?
No, eye is not painful. Eye is not very painful. Eye is like this. Eye looks a little white, but obviously the patient is putting photo drops, etc. after prednisolone drops after the eye. So basically, point is, if there is no obvious reasons of this kind of striate keratopathy on the first post-op day, you need to rule out toxic anterior segment syndrome.
Okay.
So that is what I was trying to tell. If there is severe inflammation or even a limbus to limbus corneal edema like this on the first post-op day, you need to rule out that whether it is TAS or not. And this kind of patients need extensive like immunosuppression with steroids, topical steroids, and you'll have to give oral steroids also. Some people can give intravenous methylprednisolone in such cases also. Obviously, you need to rule out endophthalmitis. I'll go next day, but definitely remember that tasks can appear like this on the first post-op day. Endothelial decompensation can be there. It may not improve in 1 month or so. These cases might need endothelial keratoplasty later.
Yeah, and TAS could find the anterior segment only, but in endophthalmitis will be vitritis and pain.
Yes, what? No.
Endophthalmitis, there is pain and
vitritis can be a differential diagnosis, but for you to make a diagnosis of endophthalmitis, there should be hypopyon. Okay. Clinically, and the vitreous should show some echoes on ultrasound. Because endophthalmitis means the inflammation is everywhere in the anterior segment and in the posterior segment. So if somebody is saying the posterior segment is very clear and there is no hypopyon as of now, so definitely you need to closely follow up such cases and you need to rule out if there is any infection or not. But as of now, in this clinical scenario, the diagnosis should be TAS and with corneal like involvement.
Okay.
Okay.
Thank you.
Yes. I think we are already. We'll continue for 10 more minutes. So this is a patient who has come to you with severe pain. He had underwent some surgery few years back. So what do you see? Any candidate who has not answered? Dr. Abdullah Irfan.
Hi, sir. Good evening.
Good evening. Please introduce yourself.
So I'm Dr. Abdullah. I'm from Pakistan.
Okay. What do you practice? Do you practice any specialty, Dr. Abdullah?
Sorry, sir.
Do you practice any specialty, or you are like
No, general ophthalmologist.
general ophthalmologist? So what do you see in this patient, in this eye?
Sir, this is an anterior color photograph of the right eye showing mucopurulent discharge.
How do you know it is right eye or not left eye?
Sir, it's not a complete picture, but I'm suspecting the punctum. Yeah.
If punctum is there, is it right eye or left eye?
The punctum is not visible.
No. What is this? This area is seen. You are seeing something, no?
Ah, yeah, this one. Yes, sir.
So which eye is this?
So this is the left eye.
So not comment. You said right eye. Just focus on what the examiner wants to say. Do not go here and there, and because they will be in trouble.
Right.
If you are sure that about the eye, say. Otherwise, you say that this is an anterior segment photo and just focus on the anterior segment findings which are there. So do not commit anything which you are not very 100% sure, because examiner can take you to somewhere where you do not want to go.
Right.
What do you see here?
So it shows mucopurulent discharge. There is conjunctival swelling superiorly, and there is opaque, opacities on the cornea, and there is increased tear film. The AC in details cannot be appreciated. There is no view of pupil or iris in this picture.
What is happening to the superior part? Like the mucopurulent is attached to something over the cornea. What could it be?
Yes, it's most likely. I'm not sure if the upper eyelid is inverted.
No, upper eyelid is not inverted. It is in the bulbar conjunctiva only. So if there is something over the cornea, like in the limbus or superiorly, there is whitening, what could it be? The patient has undergone some surgery, etc.
So it can be.
What can it be?
If it's post-operative, it can be infected bleb.
Yes. So
it can be infected bleb after trabeculectomy.
So basically, the A is you have to also say that I think there is some corneal involvement, or basically because the image is not very clear, you can say there can be an exudate in the chamber, or the cornea is white and they are mucopurulent discharge with in the superior conjunctiva. I think there is a bleb. So most likely this is a bleb-related endophthalmitis. So you'll have to read how to evaluate bleb-related endophthalmitis and how to prevent that and how to manage that. So because we are running out, this is a patient, Dr. Malk. You have not answered anything. So you will take this patient underwent secondary IOL and he comes to you on the third day post-operative with this kind of picture. So how will you evaluate and how will you manage? Dr. Malk Yasin. This is just a mock exam. I am saying again and again, this is not like, I am not an examiner. I am just trying to help you. So I think he's gone. Dr. Malk, do you want to take this? So this is just a mock exam. You need, if you do not talk, then how do you know like how much prepared you are? And I can say from my experience, I've been doing this for a long time. People who volunteer more, they have higher chance of passing. Because once talk, you know that the areas where you need to work on. Yes, any candidate can please volunteer.
Can I answer this?
Yes, Dr. Maria, please.
Okay. This is a picture of the anterior segment. I can see the conjunctiva is congested. The cornea is filled with infiltrates. I can see a hypopyon in the anterior chamber. There are two stitches in the temporal side, I think. The red reflex is dim. I can see something like a retained matter, but I can't judge well.
What would be your diagnosis here?
Sorry?
What would be your diagnosis, working diagnosis here?
I think this is a post-operative endophthalmitis. This is comes in the first.
Okay. How do you confirm it? Confirm it to be the endophthalmitis?
I'd like to do ultrasonography.
Yes, and you'll have to do under like A also, vision also, because in endophthalmitis likely the vision will be poor. And in ultrasound, what do you expect?
I can see vitreous cells and maybe there is choroidal thickening.
Vitreous echoes, not vitreous cells, because in ultrasound you cannot see cells. You will see echoes in the vitreous.
Yeah, okay.
And
Sorry.
how do you manage such a case?
I should hospitalize this patient. Sorry. I want to take a tap from the anterior chamber. I'd like to take also a tap with a vitreous tap also. I'd like to inject fortified antibiotics.
Fortified antibiotics. How is that done? Do you inject fortified antibiotics?
Yeah, according to
No.
Sorry?
It is wrong. You do not inject fortified antibiotics. Fortified antibiotics is something which you put on that, which you prepare as eye drop. You do not say that I will give fortified antibiotics inside the eye. You prepare intravitreal antibiotics, which you will give intravitreally. So what are the antibiotics you will give, and what is the dose?
Ceftazidime to 0.2 milligram and vancomycin 0.2 milligram.
What is the dose of ceftazidime?
Sorry, 2 milligram in 0.1 milli.
You have to read
0.2 milligram in 0.1 milli.
Read about the doses of vancomycin and ceftazidime. These are very important, and everybody must remember these things by heart. And I think, look, this time is I'll just this is a short what is the finding here? Anyone can tell. I'll close at around 7:15 or 7:20. So what is the finding in the ultrasound here?
Is it TSI?
Yes,
Posterior.
yes, read about posterior scleritis. This patient has this right eye surgical repair of penetrating trauma, and left eye is having like this. So what could this be?
Intraocular foreign body.
What?
Okay.
Yes, if one eye is having like this, yes, subretinal fluid or RD, what could this be? So
Posterior scleritis, exudative detachment.
Yes, sympathetic ophthalmia has to be ruled out in such a case. If one eye has repaired corneal or a perforation with possible iris incarceration, and other eye is having this subretinal fluid, which is exudative kind, you have to rule out. So this I kept as a vasculitis patient. You need to read about vasculitis also. So I think I'll close this today. This will be available in the YouTube video of Muthuswamy Virtual University. So resources, you just definitely read Kansky and American Academy of Ophthalmology basic clinical science courses. Read at least try to read Kansky and try to remember all the images. So and also one thing I tell other candidates is like you can read the book and then on the next day you just hide the figure legends and try to remember what the image says. So if you can remember all the images of this thing, the Kansky, then passing apheresis will be easier. So I think I'll conclude here, and best wishes to all of you. I hope it helped you in some way or other. Just try to find out the weaknesses where you are like you need to work on and focus on those. And definitely keep on reading. Specifically try to practice the specialties which you are not practicing. Okay?
Thank you, sir.
Good day.
Thank you, Dr. Koushik.